wanna just.
All right, we're gonna talk about it. So number one, tell me your name and read me the question, please. Give me the answer.
Catherine, and tell me your name. Okay, read the
You're sitting in a
question.
different seat.
Yeah, that was too far away.
You can't do that.
I couldn't see.
I don't
I'm
even
gonna play
hear you.
musical. I'm gonna play musical chairs with you.
Then I'll
All
stay
right,
here.
Catherine.
Okay. A patient may elect to assume a relatively small statistical risk of exposure to ionizing radiation to obtain essential diagnostic medical information when. You want any questions too? Or they want to?
Just tell me the answer.
Answer, what did I put?
All three.
I think I put T. What did I put? Circle. D.
D, good. So a patient is assuming a risk of radiation when they have some kind of illness occurring, injury occurring, or a specific imaging procedure for a health screening purpose. Meaning mammography, really. Mammography is the only screening tool we use. All the other ionizing radiation is not proactively, but after the diagnosis. Number two, will you tell me your name, please, and read the question?
Me, Nicole.
Nicole.
Effective measures employed by radiation workers to safeguard patients, personnel, and general public from unnecessary exposure to ionizing radiation define. And I put
C, correct. This is radiation protection. Number three, Jenny, will you read me the question and the answer?
Which of the following is a method that can be used to answer patient questions about the amount of radiation received from a radiographic procedure? B.
B, BIRD. What does BIRD stand for, someone?
Background equivalency, radiation protection.
Background equivalent
Radiation tech, yeah.
Good.
Good job. You got
All
it.
right, number four, can you tell me your name and
And I'm hoping I say the right.
Okay.
The
Oh, I thought it
term
was
authorization
protection.
for radiation protection is synonymous with the term. I
Time.
would say
A, ALARA. So ORP is an older term. Sometimes they're trying to bring it back. You might see it in the text. ORP is just another term for ALARA. So keeping the radiation dose as low as possible. Kieran, can you read me the question?
Monitoring and reporting of the patient dose for computed, is it tomography?
Tomography, yeah.
Tomography evaluation procedures can lead to see a reduction in patient radiation dose.
Correct, a reduction. So monitoring and reporting these doses for CT is always going to lead to a reduction because we're going to be aware of how much we're actually exposing someone, so we're going to want to decrease it as much as possible. Number 6. Shelley.
The amount of ionization produced in the air when ionizing radiation is present is known as D.
D, exposure. Correct. So this is the amount of ionization produced in the air. We're also going to talk about something called air kerma in this class. So it's a different measurement device, or not a device, a different measurement tool that we use to record the dose as well. Number 7. What's your name?
Sienna.
Sienna.
The degree to which the diagnostic study accurately reveals the presence or absence of disease in the patient while adhering to radiation safety guidelines defines which of the following terms. I put D.
D, diagnostic efficacy. So remember, how important is it for the patient to have this exam? Is it really going to benefit in the aid of diagnosing them, or are we just doing it for protocol? Right? So we're dealing with radiation and x-ray, so we want to make sure the diagnostic efficiency is as high as possible.
Natasha,
Natasha?
question number 8.
Sure.
Millisevered is equal to, answer is C, because milli means 1,000.
Correct.
So it's 1,000 millisievert.
Perfect. So 1/1000 of sievert. So MSV, millisieverts. Number 9? Megan.
So, number 9, an effective radiation safety program requires a firm commitment to radiation safety by SFA.
Ooh, anybody got anything different? What do you guys have? All right, D. Should be D, right?
D is a dog.
Should be D as in dog, right? So it facilitates providing imaging services, radiation workers, and patients. So all of these are committed to providing radiation safety. Why? Because your patient is going to be doing the research hypothetically before they have the exam. And then following up to the exam, we're going to have a conversation with the patient and educate them. All right. Number 10, Mia.
My book was different than the question, the questions.
Okay.
If a child receives a dose of radiation in a CT scan where adult protocols are used, the child, because of being smaller in size, will receive a, and it is B.
B, correct. A higher effective dose than when an adult, but the image produced will be of acceptable quality. So obviously we never want this to happen. Pediatric protocols are set in the CT machine, so it should never happen. Never seen it happen, but the image would be acceptable and we could call it diagnostic, but they would receive a much larger dose, so we don't want that to happen. So think about the technique that you set for an infant chest versus an adult 300-pound chest. Same kind of thing here. We have post-processing techniques, so we can still see the image and the diagnostic qualities that we need to, but we never want to expose this person more if we don't have to. All right, so your questions I did not grade on specific answers, I just graded on completion. All right, so that's why we went over the answers today.
Thank you.
All right, so we are gonna kind of skip chapter 1 in pathology today. We're gonna come back to it after I lecture a little bit, only because you don't really need me for chapter 1. It's just a bunch of terms that we're gonna come back to. So we're gonna start in chapter 2 in specialized imaging techniques. And this is probably a really good start for your project. Oh, when you email me, would you mind putting if you were a senior or a junior? So I'm saving a bunch of your medical records right now with the COVID vaccines, and I want to make sure they're filed correctly on my computer, and I'm having a hard time remembering which class you're in. So anytime you email me, just make sure I know your name if it's not in your email, and make sure I know if you're in the senior or the junior class.
Do you care if we email you from the FSCJ email or just like our personal email?
If you email me from your personal email, if it's hotmama99, like I need to know your name. I don't care if you email me from your personal one, but I need to know.
So it was easier
Yes, it's easier, but if you put your name, I know as well. Okay, so your name and if you're in the senior or the junior class. All right, so let's talk about chapter 2 here. Chapter 2. All right, so starting on page 15, does everybody have the same book for this one? Hopefully. Orange book? Yes, 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 hopefully.
I think that was the only option for this one.
Okay. All right, somebody in the junior class has like a blue one, but I don't know, maybe they brought it early. I don't know. All right, so specialized imaging techniques. So we know that radiography is our basis here, right? We're starting with X-ray. You guys are in the X-ray program. If you so choose to forgo more educational requirements and more clinical requirements, you would be able to obtain more modalities. Hopefully that's what you're going to do to make you more marketable. The X-ray market in Jacksonville is very good though. It's not flooded despite what you might hear. There's plenty of job opportunities. There's a ton of travel opportunities right now. I'm getting emails like every week that I'm sending out to old employees. So if you want to travel, the market is hot right now. They want to pay you. It's crazy right now. I think they're paying X-ray techs like $3,000 a week and stuff like that.
Yeah.
When you graduate, go ahead and travel for a little bit.
Yeah,
Right?
get
So
some
sometimes
money.
you have to make a commitment.
I wish
Usually
I
the
could.
traveling jobs are like 13 weeks. So it's kind of hard to be away if you have family, but if you don't, good opportunities right now, especially in the world that we're living in with COVID.
Mm-hmm.
All right, so the first of the new modalities was ultrasound. We're starting on page 15. So modalities, the first one to break out was kind of ultrasound. It was developed in the 1970s. So how is ultrasound working with our bodies? What is it able to tell? How can we use it? I like to think of it as a flashlight. So you guys, if you've had an ultrasound before, they have a transducer. It's kind of like a little wand that they kind of use on your body wherever they're scanning. Think of it more of like a flashlight. It's really cool because as you turn the transducer, you turn planes. So if you keep it straight, you should be in a mid-coronal plane. If you turn it 90 degrees, you're in a mid-sagittal. So it's a really cool tool to produce cross-sectional imaging. However, the view is really limited. So that's why I say kind of imagine it as a flashlight. So think of it as a beam shooting straight through the person. When you move it, that's the only direction that you can see. So it's not like X-ray where we have this large imaging picture or plane that we can see, or a CT that takes a whole image of your whole body. Wherever you direct the transducer is where you're gonna be able to see. So it's really specific to the area. So it really needs to be something that's localized, not chronic throughout the body, because we're not gonna be able to ultrasound your whole body. That would take a year. We don't wanna do that. It is cool because it is not using ionizing radiation, right? Everybody knows that, I hope. We don't use ionizing radiation in ultrasound, it's using sound waves. So it talks about here on the bottom of the page, how it basically helped develop CT. Because ultrasound was the first cross-sectional imaging used, it kind of was the bridge to make CT happen. So CT is the bigger picture, it uses ionizing radiation. Ultrasound is the little baby picture. We look at smaller things on a smaller level, smaller scale. Composition, really. All right, so flip the page, we're going to page 16 here. It gives you a little introduction to MRI, talking about how clinicians image with high resolution soft tissue imaging to tell the difference between functional tissue or not. CT and MRI are obviously our main cross-sectional imaging modalities. Top of the page 15, if you're a little confused. No? 16, sorry. 16.
What edition is yours?
It is the 6th.
My MRI is on page 24.
It's just a one-sentence introduction.
Oh, okay.
Yep. Yep, one-sentence introduction, top, couple lines down on page 16. All right, so first let's talk about imaging features. Imaging features, second column, hopefully everybody's tracking here. They give you a nice little chart here. So summary of imaging descriptors. Has anyone read a radiology report? Anybody got the opportunity to do that? Follow up on a patient, something like that? Read your own, maybe?
Yeah.
All right, so radiology reports sometimes will have different terminology that you might not understand. You can think about it, since you are in the healthcare field, and kind of empathize with your patients. These terms can be hard to understand if you don't learn them. So when they get that report back in the mail or in an email or something, it's very confusing at times. So these terms kind of help you navigate through the radiology report. So these are terms that the radiologist would use, or a starting place to describe the pathology that's present. So look at the purple chart on page 16. First, we want to know where. Where, obviously, that one's pretty easy, right? Where is it? The location, the lateralization, is it medial or lateral? And the relative position to the organs or the vessels. Is it posterior? Is it anterior? Is it superior? Is it inferior? Is it retrograde, around the kidney? Where is it located in the body specifically? That one's a pretty easy one. Then we want to talk about the size. So maybe the diameter or the width or the length. Sometimes they measure in millimeters, sometimes they measure in centimeters, depending on how large the pathology is present. Usually going to be very specific to the actual imaging procedure. If you're talking about a femur x-ray, what the size is probably going to be in centimeters or inches if it's a laceration or a fluid-filled pocket. If you're talking about a nodule on the thyroid, it's probably going to be millimeters. Really common, really typically a benign pathology, but they follow up on it year by year, and they're measuring very, very tiny amounts, millimeters. The density, the relative, is it relative to surrounding tissues? Is it isodense, hyperdense, hypodense, radiolucent, or radiopaque? So the first terms that they use here, isodense, hyperdense, hypodense, those are terms that they translate in ultrasound to hypoechoic, echoechoic, isoechoic. You do not need to know those terms. We're not going to go that deep into ultrasound, right? I'm not trying to make you an ultrasound tech because I'm not one either. But radiolucent and radiopaque, hopefully you know those terms, right? What's the difference? Radiolucent
Whatever is black.
Radiolucent. You can see
Yeah.
through it, good.
So
You
black.
can see through it on an x-ray, so it's
Blackness.
not going to impair the x-ray at all. It's not attenuating with the beam's going right through it, we won't see it on the image. Radiolucent, my shirt, right? I could wear this shirt for a chest x-ray, it's good. Okay, how about radiopaque?
Yeah.
Contrast, radiopaque, most contrast agents, aside from negative contrast agents, right? What else? What else do we got? Radiopaque?
Shows white on them.
Shows
Yeah.
white on the image. Okay, radiopaque, obscured by the x-ray beam, right? It's attenuated, so we can see it on the x-ray. So whether it's a bra strap or a tooth filling on a skull x-ray, or, I don't know, a shoestring, an eyelet on your pants, a zipper, radiopaque, it's showing up. So when we describe pathology, we want to say, can we see the things behind it? Are we able to see through it? Is it radiolucent? Is it radiopaque? Is it, describing the density of the surrounding tissues is really gonna be the density term. All right, so structure. Structure, is it heterogeneous or homogeneous? Is it septate or fluids? So the structure is gonna be, actually, you could write contents or composition beside it is a synonymous term for it. So what is it composed of? Or what do we think it's composed of? We can't be 100% sure, right? We're not inside the person's body. Ultrasound is the best modality in allowing us to see the structure. So that's why we use ultrasound specifically. If you want to write that one down, probably a good thing to know. Ultrasound differentiates the structures. So we're able to see, is it fluid filled? Is it pus filled? Is it a mass? Is it fat filled? So they're really able to use ultrasound in a number of ways throughout the body in those small areas, because if there's a suspicious lesion anywhere, like say you have a mass in your belly, they can ultrasound it and tell you immediately, oh, it's just a lymph node, or it's a hypoadenoma, it might be a fatty nodule, it's benign, it looks suspicious maybe. We need to follow up with further imaging. Same with the breast. If you've ever had a cyst in your body, we ultrasound anything that we find on mammography because we can't see the composition of it. We can only see where its location is. So mammography is kind of the screening map for ultrasound. So we take a mammogram, see the entire breast, and then we take the ultrasound, which is our flashlight, and kind of hone in on the area of interest. That's how we figure out if it's a mass that needs to be biopsied or not. Does it look suspicious or does it not? All right, the shape, really again gonna depend on where it's located in the body. Is it tubular? Maybe it's a vessel or some kind of muscle. I think cardiovascular when I think tubular. Is it nodule? Maybe a tumor or a lymph node. Is it reticular? Resembling a net. Reticular things are not good in your body. If you ever see that word on a report, it's not a good thing. Resembling a net means it's traveling not in a normal manner. So suspicious, suspicious. Striated or diffuse, so streaky or widespread. So shape is really, really important. Now shape, guys. Just a little draw in here. I'm not the best artist, but. All right, so striated. Striated. So this is a good striated mass. This is a lobular mass over here. This one is preferred. This one is scary. If you've ever seen anything on radiology report, on x-ray, maybe mammography, maybe CT, maybe MRI, but striated, streaky, or diffuse. So if you see something that is maybe smaller, you can't really tell. Can't really tell if it's striated or not, but then you see like streaking, maybe it looks like calcifications, almost like vessels away from it, also dangerous. So we don't want those guys. So the demarcation, it says sharply marginated, more like benign, or indistinctly marginated. So think marginated, can you see where it ends? If you can see it's only right here, probably a good thing, probably benign. If you see, I don't know, I kind of think it's behind this area on the leg, but I can't really see where it ends, probably more dangerous. So you will see radiologists are really good vague descriptors. So their job is not to tell us exactly what it is, but kind of a roundabout area of what it may be for follow-up testing. They're never gonna say, this is 100% carcinoma. They're never gonna say this is 100% not carcinoma. They will say benign appearing or carcinoma characteristics appearing. So very vague, and it's just for malpracticing, kind of not a good thing. I wish they could be a little bit more specific, but they've got to kind of cover their ground there. But like I said, the radiology report is going to kind of follow up for testing, so it's a good starter place. But if you ever do feel some kind of mass, structure, abnormality in your body, go get it checked out ASAP, right? Don't wait. I know there's kind of like that denial period. Working in mammography, I saw this so much with so many patients. You know, they would say, oh yeah, well I felt this mass like a year ago, but it started growing, so I thought it needed to be checked out. No, if you feel a mass, go get it checked out today, right? So stop it while you can, get treatment if you can. Of course, we can't force anybody to get treatment, but it's just a situation that can typically be resolved before it metastasizes out of the area of concern. Perfusion. So is it peripheral, homogeneous, or heterogeneous enhancement? Perfusion is used for specific imaging, so you're not going to see any of that in an X-ray report. And then the integration, it says the space occupying effect. Is it within an organ? Is it in the kidney? Or is it just in the space around the kidney? Is it on the vertebrae? Or is it near T2? So just the description of where it actually is. Is it occupying a space or an organ? All right, so the first one here, well actually they talk about mammo first, I'm sorry, not ultrasound. The first one here is mammo, also known as FFDM, so full field digital mammography. So mammo got an update from the film world about 20 years ago. When they used to use film, the dose was very high. They converted to digital imaging or full field digital mammography, and the dose was decreased drastically, causing a decrease of risk. So when our patients screened, did I talk to you guys about screening versus diagnostic, or was that my other class? Don't know. All right, so let's talk about it anyways. I'm getting confused teaching back and forth. I'm probably teaching you guys the same info. All right, so mammography, diagnostic versus screening. So screening is going to be anytime after 40. So when you're 40 years old, you get your first screening mammography, asymptomatic, you have no masses, you have no lesions, you have no nipple retraction, nothing going on. It's screening, we pay for the services here in America. Usually if you have insurance, it's covered, it's free 100%, just like a colonoscopy. These proactive treatments have decreased the effects of breast cancer and has made it possible for us to treat breast cancer very early. So starting at the age of 40, it's recommended that you get one screening mammogram a year, followed by if you feel anything or anything changes with your breast, come in immediately, and then they consider that a diagnostic study. So a diagnostic mammogram, something that would occur in your breast. Did you find a lump? Did your physician find a lump? Does something feel different? Is your breast bleeding? I don't know, all kinds of things, right? So it doesn't have to be some huge thing though. It could just be your breast tissue changes. If you're ever concerned, it's recommended that you go in. So mammography, unlike x-ray, where we normally take two 90-degree views to locate something, we take two 45-degree views in mammography. So we start out with what's called a CC. It's noted as a cranial caudal. They call it a projection, so from the cranial to the caudal, so CC. And then the second image is called an MLO, so medial lateral oblique. So we're obliquing the patient 45 degrees. That's kind of our starting position, and then we would follow up with others, special projections if needed, if anything was noted. Those are the standard protocols though. Ultrasound, also known as ultrasonography. This is kind of our go-to. It's a really cheap imaging system. It's not expensive to have an ultrasound. It's really easy to operate. It talks about here, it's widely acceptable. It's a widely accepted cross-sectional imaging technique because of its low cost, availability, and ability to differentiate cystic, solid, complex tissues. So remember, the ultrasound is going to tell us what it's made out of. So we saw something on a mammogram, and then we bring our ultrasound tech in to scan, and she's like, it's just a solid mass, it's fine. We'll look at it next year, we'll measure it. Ultrasound techs have a little bit more responsibility and accountability than us as rad techs. They are actually going to be writing down what they're seeing live on a sheet of paper. So if you ever work in an ultrasound department or near one, you'll see them kind of constantly writing. They also take measurements while they're scanning. So unlike us where we just take the picture, we might see a mass. We're not going to measure it or differentiate it. We're not going to say it's a fluid-filled mass, right? So ultrasound goes a little bit deeper as far as their modality. They are responsible for more because it's almost like a pre-reading for the radiologist. When they're scanning and they see things that are changing live before them, those images are not recorded, so it's their responsibility to document what's actually happening. Whereas opposed when they take standstill pictures, it might not actually be what's actually there. Some things are false when you're doing ultrasound scans, depending on how you're changing that transducer. So, how are the images produced? So we're going to use the transducer. There's a crystal mounted inside of it, and it's going to send signals that act as a receiver as well. So that transducer is producing sound waves. Once the sound waves hit your body or any portion of pathology, it's channeled back to the transducer that reads the image. That is basically the very, very minimum that you need to know there. Depending on how the signal's pitch and direction came back to the transducer is how the image is actually produced. Is it gray? Is it white? Is it black? How is it actually showing up on the image? It also talks about a water tissue interface that can produce strong reflections, which are also known as echoes. So anytime you see something known as a strong reflection in an ultrasound, it's just called an echo. So it's echoing back. So the transducer is going to send the signal. If it's a strong reflection, it's an echo. It's echoing back to the transducer that's reading it. So it's the producer and the reader, the transducer there. So that's really all you need when you're doing an ultrasound. The gel is just going to be able to allow more attenuation and more traveling of the sound wave. So if you ever have had an ultrasound and they put gel in you, it's just to increase mobility on the skin and produce a kind of medium for the sound to travel through. You don't need to know the anechoic, the hyperechoic, the hypoechoic, or the isoechoic. So we're going to skip over those. So again, ultrasound, it's a cheap study, very beneficial for determining and differentiating tissue types. What is it composed of? The next page here gives you a lot of examples of ultrasounds. You don't need to know these either. You're not an ultrasound tech. I'm not going to give you an ultrasound picture on an exam. So let's skip to CT. So computed tomography. So I'm on page 20. Computed tomography. So the first thing you need to know, it's within the first paragraph here. It says CT is extremely sensitive to slight 1% differences in tissue densities for comparison detection by conventional screen-filled radiography that requires differences in tissue of at least 5%. So what does that mean in basic terms? CT is really sensitive to changes. So for an X-ray to show something on the image, there has to be about a 5% difference in density. I know that we don't use the term density a lot anymore. It's kind of an old school term. We kind of bump up contrast and spatial resolution now. But as far as it showing up on the image, it would have to be a 5% difference. So think about a black versus a very, 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 very dark gray. Whereas CT can pick up things that are right next to each other. So we have a lot better eyes on the pathology and the structure of the system. It also tells you the CT number. So they call it the Hounsfield number. This reflects the attenuation of a specific tissue relative to that of water, which appears arbitrarily assigned as a CT number 0. So what do you need to know? CT number, also known as Hounsfield number, appears as gray on the image, and it is the number 0. It is the number 0. The highest high CT number, 1000, represents bone, which appears white. So this is pretty close to radiography, right? Bone is white. And the lowest CT number is -1000, denoting air, which appears black. You don't need to know that number. So you need to know the CT number. The Hounsfield number reflects the attenuation. It appears gray, so if there's nothing actually there, If it's water in your body, it's gonna be gray. The highest CT number is 1,000. It represents bone, appears white on the image. And the lowest CT number, which is negative 1,000, denotes air, which is black. So CT is a cross-sectional modality that uses ionizing radiation, can be damaging to the body, so we want to be careful when we're using it. We always want to start out with X-ray if we can, if we have the means to do so. If it's a code stroke, code blue, something like that, we'll probably move straight to CT for a stat exam to take care of the patient. If we have the time, we're always going to stop at X-ray first though. On page 21, it tells you that CT technology has moved to a spiral or a helical scanning. In this technique, continual CT scanning is performed as the patient moves through the gantry. So the gantry is that circle that you go in, the circle tube that you go into. That's called the gantry. That's your main piece of equipment when you work with a CT machine. This approach permits much faster scanning without respiratory motion and provides volumetric data that can be easily reformatted in coronal and sagittal planes and the standard axial planes. So these scanners are able to produce images of the chest in less than 20 seconds. So it's pretty fast technology, really good imaging, way more advanced than X-ray, way more radiation than X-ray. But when we talk about the helical or the spiral structure, whereas X-ray travels in straight lines, right? We know that's one of the properties of X-rays. It travels in straight lines. It could be scattered back to you, backscatter, secondary radiation. CT is using the gantry around you, and it's spinning, so it's producing a butterfly effect of radiation. So it's more like this. Spiral or helical around your body. That's how it produces the cross-sectional imaging, because it is actually scanning your entire area, whereas X-ray is traveling only in a straight line out, exit point, or behind you if it's attenuating to the IR. So helical scanning. That's really all we need to know about CT as we start here, so we're going to turn the page. It gives you some images. If you want to look over them, you can. On page 23, it shows you a really cool 3D, 4D picture, figure 2.12, the CT angiography. These are really good, high-quality scans. We also can perform this using MRI. It's called an MRA, so magnetic resonance angiography, but it's used for vessel detection. It can detect aneurysms, places that stents need to be placed, tears or ruptures in the vessel. So really, really high quality imaging that we use here. So flip the page to page 24 where we talked about MRI. This was kind of the game changer. It's one of the more newer imaging modalities. Everybody thinks that for some reason MRI techs get paid more. Not really true. I guess it depends on where you work. All of the modalities are going to pay around the same amount unless you do something completely different like radiation therapy, but it is a year program. I know that radiation therapists make like 85 grand coming out of school with no experience. So that's probably going to be your highest paid modality, at least with no experience. But all the other ones are pretty comparable to each other. Of course, it's going to be different from facility to facility. I don't even know the starting pay of an X-ray tech now. It's been so long since I've been out there, but I know that when I graduated, Memorial used to pay more PRN than Baptist, but I know that Baptist pays more in mammography and CT than Memorial does. So it really depends on where you work, kind of your scale of pay. Of course, as a new tech, you're just going to try to get in the game, right? And get a job, get a PRN job. Some places are going to cross-train you for these opportunities, some will not. Have you guys heard of any cross-training opportunities in your clinical facilities? Mm-hmm. Yes, no, maybe so. So some of them still require formal education through the ART, but you can do that through like an online webinar. It doesn't have to be a whole program like this. There's obviously a lot of opportunities that you can do here in Jacksonville because we have so many facilities. I know that the smaller imaging centers like Acumen and what's the other one? precision will cross-train you. If you start out as an x-ray tech and you kind of voice that you want to be cross-trained, they'll cross-train you for mammo, MR, or CT. So if you're willing to kind of do the bookwork online or at your own pace and submit those to the ART, you can test and they'll give you your clinical requirements. So just like you guys are filling out that running log sheet right now when you're in the RT program that I'm going to submit for you to test, there are clinical requirements for every additional certification. So CT is going to make you scan, 20 chests, 20 extremities, maybe 1 CTA, but it will make you participate in certain exams. So if you work at a facility that's open to cross-training, it's a good opportunity to advance your education free. Sometimes they will lock you in for a year though, so just keep that in mind. If there's any kind of contract requirement, if they train you, they usually want to keep you locked down for a year because they paid for your training. All right, so MRI, it uses a magnet. This is non-ionizing radiation. It talks about in the second paragraph on page 24, although the physics of MRI is beyond the scope of this book, the basic technique consists of inducing hydrogen atoms, which are protons, to alternate between high energy states and low energy states by absorbing and then releasing or transferring this energy. This absorption of energy is accomplished by placing the anatomical part to the image in a strong static magnetic field and directing an RF pulse or radio frequency pulse of a specific frequency at the area. As protons absorb energy, called resonance, they move into high energy states. After a predetermined time, the RF or radio frequency pulse is then turned off and the protons begin to release or transfer. Their energy is then absorbed and they move back to a low energy state, and this program is called relaxation, and it occurs over time. You do not need to know the difference between the two types of relaxation. They go into T1 versus T2. You're not an MRI tech. MRI is kind of hard to go directly into from X-ray because it's quantum physics, so the production of the image is different, whereas CT is still using ionizing radiation, so you already know the physics behind it. So I kind of recommend to my students, if you are interested in both, start out with CT so you can learn the cross-sectional image, how to look at the body, how to position, and then if you build and get an MRI certification, then you would just be learning the physics, not the anatomy, not the cross-sectional portion, and the image production. So it'll kind of be like a stepping stone. MRI is a high-tech use of technology for the CNS and the PNS, so we can look at nervous systems in our body. Spine work is really detailed on an MRI. The time length of the exam is drastically different than a CT though. If you've ever had one, you probably know. A CT, you're gonna be in and out 10 minutes tops, no matter what you're scanning in your body. An MRI, you're gonna be kind of sitting in the machine and you'll be hearing this knocking the whole time, right? Anybody ever had one? It's really
Yes,
loud.
hate it.
So they try to give you these headphones that block out the sound, but you can still hear something knocking. It's usually more of a cause for claustrophobia than CT because the gantry is much closer to your body. I'll tell you a story. I actually had an MRA before actually, and I am not claustrophobic. And when I laid down on the MRI table, they put this cage over my head to kind of attenuate the magnet and make the progressive pulses faster. It almost looked like a hockey mask. And I was laying down and he put it on my face and he's like, all right, everything good? I'm like, yep, take it off. I feel claustrophobic. So I had to go through it like 5 times, so I really developed some compassion. So if you are gonna be an MRI tech, just know that you're gonna have to walk people through claustrophobia all the time. You're at least gonna have one patient a day that you're gonna have to walk through. They might not have a cage on their face, but the gantry is so close. So when you lay in the machine, it's literally like right here. So you feel like you can't move. Also, the pulses and the production of the MRI takes a long time. So they'll tell you, you have to be still for 10 minutes, or don't move, your first set's gonna be 15 minutes. If you move within those first 15 or 10 minutes, they have to repeat that whole set of images. So the imaging is very slow, but it's detailed. And it's not harmful to your body. There's been a lot of research for MRI. Not a lot of research for fetal dose as far as the effects of MRI on a fetus. They will send you through an MRI machine if it's necessary when you're pregnant, but they will not give you contrast. The main difference between MRI versus CT or X-ray with the contrast agents is the contrast is permissible through the blood-brain barrier, meaning it crosses right through the placenta into the baby. And MRI contrast is given based on weight of the patient. So, I'm 120 pounds, they're gonna give me this much contrast. My baby's 2 pounds in the womb, not a good thing, right? Could definitely be toxic. They don't have kidneys that are developed yet. Even if they do, they can't digest and process all this contrast, so it could be really toxic to the baby. So no contrast if you have an MRI when you're pregnant or if you image a pregnant patient. Something to think about with MRI is there's a lot of safety behind it. The magnet never turns off. I'm sure you know that, working in the radiology department already. The magnet is always going. So if you have anything that is called ferromagnetic, anything that is attracted to the magnet, it will pull right off your body if you go into the room. So for example, if I have, I'm trying to think of which metal is ferromagnetic. Gold is non-ferromagnetic, so silver. If you're wearing anything that's silver, it will pop right off your body. If you have tattoos that you got in jail that are janky, they're gonna burn. Real tattoos, usually they don't use ink that have any kind of metal that's ferromagnetic anymore due to the use of MRI, so it's kind of sped up to technology. Same thing with implantation of devices as far as hip replacements. They use steel, so it's not ferromagnetic anymore, right? They try to advance the technology. I'm sorry, they traveled from steel. They no longer use steel due to the weight and the ferromagnetism of the steel. Something that was really common when I screened MRI patients, when I was a radiology director, if I was catching kind of my techs up, I would screen them before they came in the room. Steel-toed boots, people don't know that they have steel in them. They're just wearing boots. I'm like, you gotta take your boots off. I had a guy try to walk in, the boot flew right off his foot, the MRI unit. So you never want anything to fly in, because if the magnet is always on and spinning, that means that it can always repel and it will retract. So what does that mean? So anything that's attracted to the magnet is gonna spin out and deflect at whatever speed the magnet's moving. So it depends on what facility you work at. The physicist determines how the magnet spins when it's not being used, but it has to be moving at all times to create the magnetic static field. If the magnet is quenched, meaning if something is pulled into the magnet and it repels out, it is very expensive to repair it. When the magnet is quenched, somebody has to come out and fix the machine. It's usually at least a couple $1,000s. Not a good thing going on, and somebody could get hurt. Pins, I've seen tons of pins fly out of nurses' pockets, loading people kind of into the MRI unit, not screened properly. So if you are an MRI tech, you're gonna be screening, patting down these patients. Do you have anything on? Probably best just to change them into a gown, right? We don't want anything flying. If you have a nose ring or a tongue ring or any earring, it's going to pull right out of your body. So always take it out. They won't ask you what it's made out of because they don't trust you. They're the MRI tech and they've had people tell them before, yeah, this is gold. It's not gold, it just flew out of your ear. It can't be. No, it's really gold, I promise. No, it's not gold, it's in the MRI machine. It's not repelled by the magnet, it's gold, I promise. So you can argue with your patients all day long, but ultimately, screen them is the best piece of advice. People have died in MRI machines by coming in with machinery or equipment that is ferromagnetic. Example, oxygen tanks.
Yeah.
They are not allowed to go in there. So you think about oxygen, it is combustible. So if it enters in the machine, they're pulling our oxygen tank in the room, it will fly to the machine and come out and probably explode. So you definitely don't want to do that. You will notice in the MRI area, they have specific stretchers that go into the unit. It will say MRI or safe MRI on it. They try to label it really large so that you don't miss it. But most of the techs are really good at screening the patients. But again, safety is a huge, huge thing here. We don't want anybody getting hurt. We don't want the magnet quenched. We want to perform the exam safely. Whereas CT is able to blur out the respiratory functions and create a sound image, MRI is not. So they will even tell you, breathe very paced. So don't even take a deep breath in, because if there's any motion on the image of the set, of the small area that they're imaging, they have to repeat that set. The reason why they started doing sets is because if an exam is 45 minutes long, and somebody moves, they would have to repeat the entire 45 minutes. So they started chunking them up. It's department protocol, tech specific, however you like to scan, you can set these things up. Really, really cool technology that it's advancing for MRI now is called tele-MRI. They just put it out in Mayo. I don't know if you guys have heard of it. It is the ability to basically scan at home. So the MRI tech can be at home in their PJs. Mayo has already set up their office space with all of the equipment that they need to scan, all of their buttons, all of their computers, the technology that they need to scan. And then they have like a tech assistant, so somebody who really doesn't even have a BMO or any kind of x-ray license in. They'll position the patient. You'll say, okay, it's a skull, put the patient in head first, put this on their face, make sure you screen them, obviously. We're not using contrast, so I don't have to be there, radiologist doesn't have to be there. They'll set the patient up and then you control to scan the patient.
That sounds scary.
It's really cool.
That's awesome.
Yeah, it's really, really
Stay
cool.
on
So
that.
technology is already advancing, you know, in 5 years we're gonna have to learn something new probably. That's why we're practicing medicine. Same thing going on with nursing right now. There's a lot of telenursing right now, especially with the pandemic. I do know a couple of my friends that work at Mayo as well, and they telenurse. So they have all of the vital signs, all of the computers up. They might have 2 patients, 2 cameras on the patient. They're at home. They only respond to them if their vital signs decrease. They can even control their actual IV line. So they can choose to stop it. They can choose to have a computer or a person release medicine into the IV line directly. So medicine is changing. But hopefully you like people, and that's why you're in this field, right? So you may end up working with just computers one day, but hopefully you do like people. So MRI, super, super cool imaging, lots of cross-sectional anatomy, long extended times for exams. Let's take a pause before we go into nuclear medicine. I see some people drifting. All right, let's come back at 10, and we'll go over nuke, SPECT, and PET, and then I'll give you guys your assignment from chapter 1. So take a break, take a walk, get some water. Something in the body that is radioactive, right? So it can be ingested, it can be injected with IV, intramuscular, IM, lumbar punctures, intrathecally, or into a shunt. So basically, they pair a radioisotope with a pharmaceutical, so some kind of carrier, if you would. So if you insert these with IVs, if you ever become a nuke med tech, you always have to wear gloves. So you might see the scary looking scientific lead gloves that they use. Does anybody see those being used in fluoro these days? You do? Okay. All right. So we know that they are radiopaque, so you can't use gloves if you want to see beyond the glove, right? You have to use a paddle that's translucent or radiolucent. But if you use the gloves, they do protect you from the radiopharmaceutical if you're working in nuke med. Something to note is these patients also have their separate own bathroom because they are ingesting or injected with radioactive pharmaceuticals. When they use the bathroom, their urine will be radioactive or could contain a radiopharmaceutical if it's not processed completely in the body, depending on what kind of study you're doing. So you'll see like a patient-only bathroom. You'll also see an area where you can dispose of radiopharmaceuticals. It's normally a black bin. Really important that they're not pouring these down the drain, obviously, so we're not drinking radioactive water or whatever, but we need to dispose of these properly, so you would see a bin for that. You also might see what is called a Geiger-Mueller counter. So we're going to talk about that when we talk about dosimeters in our Rad Bio book. It is just a measuring device to measure radiation within the air. So if I used a radiopharmaceutical on a patient, they went to the restroom. I wanted to see if the room was radioactive or the air or the toilet or the water before I brought the next patient in. You can bring out a Geiger-Muller. It's kind of like those thermometers that they're using for your forehead, but it looks like that, kind of like a gun shape, and you could track to see if there's any radiation or residual secondary radiation in the room before you bring in the next patient. So basically, this machine in Nuke Med is going to use a gamma camera. It's made of sodium iodine crystals that detect the radiation that's being emitted from the patient. So an image is created from the gamma rays that are radiating from the patient. The radiopharmaceutical dose is based on the calculation of the basis of half of the specific half-life of the material. So there's an image over there to the side on page 28. It's figure 2.18. I have no idea how to read these images. I don't really know what they're showing other than it looks like a skeleton to me, right? It's a full body scan, anterior and posterior. So remember, these images are produced by radioactive material, radiopharmaceuticals being emitted from the patient. And there's a device known as a gamma camera that picks up the reading and the recognition of the radiation being emitted. That's how the image is produced. So obviously wouldn't want to do these studies on pediatric patients, wouldn't want to do them on pregnant people, right? Lots of radiation. And it's using a different type on the EM spectrum known as gamma. So we are going to talk about that next week in Rad Bio. So we'll talk about the different types of rays like gamma and alpha, how damaging they are, how penetrating they are. So you guys know everything on the EM spectrum is traveling at the speed of light, right? It all has no mass, no weight to it. So once you actually gain a mass or gain a weight to the material, it's called particulate radiation. So think particulate radiation. It's off the EM spectrum now because it actually has mass and weight to it. And then it can become gamma or alpha depending on what it mates with almost, what it pairs with. So we're going to be talking about that next week, so kind of get your brain in that manner. If you're reading ahead of the book, I think it's chapter 2 that we're going to cover next week if you want to look at it. It may seem a little confusing if your physics basis is weak, so we'll go over it. All right, then we are going to go down the same page on page 28 and talk about SPECT imaging. So SPECT, so single photon emission computed tomography. So they compare this to CT, but in SPECT, instead of the source, the X-ray tube, and the detector array moving simultaneously, the source, which is the patient, emits the signal while the detector array rotates. So think about it kind of opposite CT. Again, they're going to be using a radiopharmaceutical. It's similar to Nuke Med in that manner. So they're going to inject, or the patient's going to ingest something radioactive. But instead of the radiation spinning around them, the IR is spinning around them. So that's how they're creating the image, okay? Because they are emitting the radiation. So no gamma camera used in SPECT. We are specifically using the IRs that are rotating around. It talks about the SPECT cameras that basically recreate 3D slices of the image and orient to the body. So again, page 29, figure 2.20 is a SPECT image of the brain. It says it's in 3 planes. I wouldn't know. It looks like just kind of like a grain to me. Transverse, sagittal, and coronal. These imaging modalities are not as common. You're not going to see a lot of people working in these areas. I don't know that we have a local program for SPECT at all. And then, I believe this is the last one, besides fusion, yeah. So PET is our last one, just to kind of round the corner. So PET scan, positron emission tomography, very similar to Nuke Med with one difference. The type of radiation that's emitted. So radionucleotides used during the general nuclear medicine, emitting during radiation would be the nucleus of the atom, whereas PET, a positron or a positively charged electron is emitted. So it's just the type of radiation that's released. So it talks about right here, Nuke Med, radiation being emitted directly from the nucleus of the atom. PET specifically, a positron is gonna be emitted, which is just a positively charged electron, which doesn't make sense to us, right? Electrons are negative. How are they positive? We're gonna talk about it in red bio. Also, something important to know is that as a release of this, 2 gamma rays are emitted in opposite directions. So important to know for specific PET imaging, 2 gamma rays are emitted in opposite directions. So PET uses camera systems that are traveling in different directions, 180 degrees, and they detect the photons that are being produced and the positrons.
You said 2 gamma rays, what?
Are emitted in opposite directions.
Thank you.
Yep. If you turn the page, it will show you a SPECT image on page 30, and then there's 2 PET scans. So figure 2.22 is a PET scan, and then figure 2.23 is a PET scan. Again, I'm not familiar with these modalities. We just need to know a foundation. Why is it important that we're educated on other modalities? Because we can refer the patient. So we know the process of radiology. Almost everything starts in x-ray. If you're not pregnant, you can have an x-ray, right? If you're pregnant, they're probably gonna go the ultrasound route. But we need to know a baseline reference so we can educate our patients. So that's why it's important. There is a small portion of the registry that's on generic radiology questions. So that's why we educate you on this. Not just to push you and make you continue your education, I promise. But there are a lot of local programs. I don't know if you guys have checked them out. There's UF Health, they have a lot. They have Mammo, MR, CT, and I think they have radiation therapy too, because they have the proton therapy system. So if you're interested in that, there's an opportunity. St. Vincent's has an ultrasound program if you want to bridge to that. There's a company called Pulse Radiology that will allow you to set up clinically with you. They're paired with Baptist and partnered with them. They have contracts so they can place you clinically within the modalities. And then the schooling portion is just virtually. So you attend like virtual sessions and it's kind of like an online class. So you would be eligible to test for the ART certifications if you are interested in any of those. And then of course there's the opportunity to cross-train depending on where you work. So lots of fun, exciting opportunities for you guys. We don't need to know anything about fusion testing. There are no questions on the registry about it, so we are going to skip over that. Fusion is just what it says though. It's a fusion of multiple different uses of radiation. So sometimes it's fused nuclear medicine and PET, sometimes it's PET and SPECT. It depends on the machine. Very, very expensive imaging to make these machines and units. I would not recommend the chapter questions for this. If you want to self-study, don't do them because they include a lot of garbage information that we don't need to know and that we don't want to know. So next we're going to go back to chapter 1 and I'm going to give you some time. I'm not going to go through this chapter because basically it's just terminology. So I want you guys to define the key terms. Define the key terms. They're on page 1 of the textbook. There's a lot. There's a lot. I'm just going to warn you.
Page 1 on the textbook.
Yes, page 1. You can work together if you want. Work together if you want to now.
Oh, right now.
Yes. Yes, you're going to turn it in.
Chapter 1, you said?
Chapter 1, yes.
We're doing it now.
Are we turning this in just on paper, just paper?
Paper,
Today?
or you can type it if you want to. Do you guys want to turn it in tonight, in case you want to do it on your computer?
Yeah.
The book's supposed to be delivered tonight.
All right. Should I do it until Friday? Can you have it done by Friday?
Yeah.
Okay, all right. So I want you to review the key terms. You need to define them. You need to write them down or type them, whichever you would like. You learn by repetition, it's proven. If you want to do flashcards, you can too. I don't know how you would submit this to me. You can show them to me if you want to. I'll be here Friday, I guess. But I need them either on paper or some kind of document typed. But remember, the research is proven, repetition is how you learn. So I really highly advise flashcards, especially specifically with positioning, because there's 64 questions on your registry that is gonna be on positioning, and it is the lowest area because there's so much information to study. So really, really try to grind it out with some flashcards. But that's all I have for today. I just need you to know the key terms from chapter 1 before we move on, and I can meet with some people if we need to. Yes?
Are we gonna have a quiz or test on this?
Sure. At some point.
Are we gonna be able to submit this through Canvas?
Yes. Yeah, I'll make a link on Canvas if you wanna submit it. Yep.